Advances in the treatment of diabetes. Where have we been and where are we going? Dr. Sarah Linklater is Chief Scientific Officer of JDRF Canada, a role in which she oversees projects funded by the organization in Canada, advances research partnerships, and supports efforts to engage and advocate for the T1D community through research communications. Sarah is interested in all things type 1 diabetes, access to insulin around the world, and in patient-oriented research. Dr. Alice Cheng is an associate professor at the University of Toronto and an endocrinologist at Trillium Health Partners in Mississauga and St. Michael's Hospital in Toronto. Alice has made educating healthcare providers and those with diabetes a key part of her practice. Dr. Bruce Perkins is a professor at the University of Toronto, an endocrinologist and the director of the Leadership Sinai Center for Diabetes. His research focuses on diabetes complications and new approaches to day-to-day blood sugar management. In addition, Bruce does extensive work in education and advocacy for those who, like himself, live with type 1 diabetes.
Hello, everyone, and welcome to this session about advances in the treatment of diabetes. Where have we been and where are we going? I'm delighted to be moderating today's session on research with Dr. Bruce Perkins and Dr. Alice Cheng. So it is research that has totally transformed the treatment of diabetes. As we've been discussing, it all started about 100 years ago with the discovery of insulin right here in Canada. About 50 years ago, research enabled the development of synthetic insulins, which has allowed much more precise dosing and flexibility with insulin treatment. Also about 50 years ago was development of the first insulin pump, which was as big as a backpack. Now we have several different types of insulin pump available, and there are many more now in development too. Around 40 some years ago, scientists figured out that type 1 and type 2 diabetes were very different diseases, with type 1 being caused by autoimmunity. Even more recently than that, scientists have learned a lot about the inner workings of beta cells, which are the insulin-producing cells that are either damaged or don't work well in people with diabetes. Now, many clinical trials are underway that test therapies that could keep beta cells healthy, regenerate them, or even replace them using an implantable device. Around 35 years ago, the risk of blindness in people with type 1 diabetes was around 50%. Now, in North America at least, it's more like 5%. And new therapies are being worked on all the time to reduce the risk of this complication and many other complications even further. Despite all these great improvements, there's still a long way to go to reduce the burden of living with diabetes, and most importantly, to find cures. But we are in an incredibly exciting period of diabetes research right now, and the time we have today is really only enough to scratch the surface of everything that's going on. But we hope to bring you some highlights and really illustrate the promise of research to deliver better treatments, better lives, and eventually cures for diabetes. I'm delighted to be moderating today's session with Dr. Bruce Perkins and Dr. Alice Cheng. Hi, Bruce. How are you today?
Oh, I'm really well, Sarah. Thank you so much. I'm so glad to be taking part in this.
Great. And hi, Alice. How are you doing?
Hi, Sarah. It's great to be here, and welcome to everybody for joining. And it's always a pleasure sharing a stage with both you, Sarah, and Bruce.
Great. And so turning to Bruce, first of all, for our first question. We've learned a great deal about diabetes prevention in recent years. Can you tell us where we're seeing the most exciting progress in this area?
All right. Well, first of all, just in brief, remember there's type 2 diabetes and type 1 diabetes. And though, technically we don't know the causes of each, we know, as you say, they relate to type 2, insulin resistance and ability to make enough insulin in the face of insulin not working so well and having to make large amounts. So type 2 diabetes prevention, a lot of it has focused around healthy people just having healthy lives in order to minimize the effect of those things that contribute to insulin not working so well that they can control. And so that usually has to do with how physically active, how physically fit we are, and what kind of diet we're eating. Whereas the things we can't control, because a lot of type 2 and type 1 occurs through no fault of our own. There's a lot of factors in type 2 that we can't control, the genetics. So most of the prevention has been around identifying people who have kind of gray zone, not quite abnormal blood sugars, but not quite normal either. and targeting them for improvements in diet and exercise, but also certain medications. And there's kind of 3 classes of medications that have been approved for use, but they don't add much more to diet and exercise. But that's the first thing around type 2 diabetes prevention. But maybe you were asking me more about type 1 prevention. So type 1 diabetes, we know that it's tough to identify who on earth is going to get it. It happens out of the blue through no fault of our own. But we know that the risk is quite a bit higher in people who are family members of those with type 1 diabetes. So in the general population, it's about 1/3% lifetime risk, but it's probably more about 5 to 8% in someone who has a family member with diabetes. So that's a much, that's like a 15-fold higher risk, but it's still a pretty low risk overall. So within those people, there have been research trials that have looked for antibodies, things we can measure in the blood that show that our immune system is attacking insulin-producing cells. Now, not everyone with type 1 diabetes will have these, even though they may get diabetes, but probably the vast majority do. And so those people who've got those antibodies plus some abnormality in their blood sugar are likely at extremely high risk. And they have now been targeted in trials using immunosuppressive medications. And there's been a huge finding in the last year or so with a medication called teplizumab. Teplizumab, it's a monoclonal antibody. It attacks a part of the immune response, happens to be the CD3 cells. What it's been shown to do is delay the onset in these high-risk type 1 diabetes people, delay the new onset of type 1 diabetes by about 2 years. And so right now it's under review with the FDA. It's under this thing called the breakthrough review, which means it's being evaluated more rapidly than typical medications. And at the same time, they're studying how effective it could be if they repeat doses of it, because in this trial it was only given once over 2 weeks, and also some further studies in people with new onset diabetes. So this is a big area. In my own opinion, I think this looks like it could be kind of game-changing. It means we're going to have to now shift to understand who's at risk better and figure out in clinical practice who we can identify who's at higher risk, and administer this medication and possibly administer at certain intervals over the years to help reduce risk, and possibly also combine it with medications that have been shown to have some effects in new onset diabetes and are now being studied in this earlier stage.
I have a question, Bruce, if I may, and for you or Alice. If I'm a regular person looking after my health and I want to know if I'm at risk for either type 1 or type 2 diabetes, how do I talk to my doctor about finding out?
Yeah, around type 1 diabetes, the risk overall, even if you're higher risk, is quite low randomly. So we need to first really start with people who have a family member with type 1 diabetes. And right now, the only way to really screen for those multiple antibodies is through a research protocol. And the research protocol is one called TrialNet. So wherever you are in the world, you can Google TrialNet and you can find a center close to you. They do intermittent testing, and now they are doing testing where you can go in for lab work, but they even have a fancier version of it now where you can do a blood test on your own at home through the mail. So it's definitely worth, if you have a family member with type 1 diabetes, it's worth thinking of reaching out to a TrialNet site.
I think in type 2 diabetes, there are multiple tools that one could use to try to determine their risk. So for example, there's the CAN risk tool. So CANRISK. One could just search that on the internet or go to Diabetes Canada website and be able to see that. And it's a questionnaire that you could answer about yourself. And it's looking at demographics, it's looking at family history, and then determining what your particular risk would be for developing type 2 diabetes. And then have that conversation with your team and see, are there things that could be done to change that? And in fact, there is a Canadian Diabetes Prevention Program research study that is available in Canada that people can sign up for. They can self-refer or their physician can sign them up. And it's a powerful program that's sort of looking at whether healthy lifestyle modifications can impact that risk. But one thing that I do want to point out, but before we move on to the next section, is the concept of prevention in type 2 diabetes. I think that word can carry with it some stigma. because unfortunately, type 2 diabetes carries stigma that is not warranted, like most stigmas are not warranted, and there's a great deal of blame on the patient. So when someone develops type 2 diabetes, people around them and they themselves feel it was their fault. But as Bruce very nicely said, the vast majority of that risk is not something they could have modified. So maybe the term prevention in type 2 diabetes is not ideal, but more the concept of reducing risk. And this was actually brought up to me when we were developing the guidelines several iterations ago. And because we had people living with diabetes on the panel, this was actually one of the things raised. So we changed the title of that chapter. It was no longer called Preventing Diabetes, but it was called Reducing Risk of Diabetes, because then it sort of takes away a little bit of that stigma that you didn't work hard enough to prevent it. But no, it's actually I'm at risk, and it's whether I can try to reduce that risk.
Thanks, Alice. Really important. So we're going to switch topics a little bit and talk about innovations in insulin therapy. So really central to today's theme, and also a very exciting and active area of research. So Alice, can you give us a little overview of where we've come with insulin therapy, where we are, and where we're going?
So the insulin story is a pretty incredible, right? And we've been talking about it now all year for obvious reasons, but the discovery of insulin was truly life-saving. And I sometimes pause and think about literally the millions of lives that have been impacted, not just at the time, but then the subsequent generations that were born that would not have otherwise been born if it had not been for the discovery of insulin. So that impact is huge. But then obviously insulin had to transform over that time because the original insulin had its cons. It wasn't perfect. And things have gotten better. Originally, it was an animal source, and then there was a way through recombinant DNA to create a more human insulin. And then there were analogs, which just means modified human insulins. But each modification had a purpose. It wasn't just modifying for the sake of modifying. The purpose was to make the insulins behave closer and closer to what your body would want it to do on its own. So therefore, needing insulins that were very fast acting to deal with food, and insulins that were more slow acting to serve as a background. And each step has been an improvement. And I often joke that unlike in people, when it comes to technology, each generation is better than the previous generation. And that's because it's designed that way. It's designed to provide some additional benefit. And the benefits have mostly been in the form of less hypoglycemia, less low blood sugars, because the insulin being a little bit more predictable, or a little faster acting or flatter, depending on when the insulin is being administered. And it's trying to ultimately mimic what the pancreas can do. And I actually not joking when I say this, the pancreas is probably the most awesome organ because of what it's able to do. And we are constantly trying to mimic that. And the insulin is one of the tools to do it. Now, what does the future look like though? So right now we already have some excellent insulins. The future looks like in the near future, for example, weekly insulin. So weekly basal insulin has already been created, is being studied, is not available yet at this point because there are more studies to be done. But that I think speaks to the importance of convenience and path of least resistance and trying to make the burden of diabetes be a little bit less. So that concept of weekly basal insulin is in the near future. And then in the farther future, but not too far, is what I think is the coolest idea, is the smart insulin. So that's almost Star Trek-y in my mind. And I'm a huge Trekkie. So that I think is such a phenomenal idea, right? Imagine just injecting an insulin that then figures out what to do on its own, that will detect the blood sugar level and work when it needs to, and more importantly, stop working when it doesn't need to. And again, ultimately reducing the burden on the person living with diabetes and mimicking what a pancreas would do. So it's kind of like a pancreas in a bottle would be a different way to think about it. So I think that smart insulin future is exciting. And every conference, there are great studies looking at it and really smart people working on it with really novel ways of making the insulin glucose sensing, which is what you need it to be. And that is in the future. And I think something that we will see in the coming years.
Could I say, first of all, I might tell your parents about what you said about each generation being better. I found that interesting. I'll tell my children about that too. Or I won't tell my children about that.
Exactly.
Yeah, exactly. This whole, the idea with insulin is that our bodies, okay, not mine, but probably, I guess yours, makes insulin in the pancreas and it goes directly to the liver. The liver is essentially where it acts. And when we're putting it under the skin, as you said, it wasn't intended to be under the skin, so it absorbs slowly and it doesn't go right to the liver. It goes all over our body, and that causes a number of problems. It might be one of the reasons why there's a bit more weight gain in people with type 1 diabetes, because there's more insulin floating around in the general body than rather just the liver. So there was this development of liver-specific insulins, insulins that kind of get caught up in the liver and act there primarily, but I think they might have worked too well because there wasn't quite enough insulin in the periphery, so that kind of helps to melt fat, but then too much acting in the liver, so it stores all this fat. So these people in these trials were getting like foie gras or really high fatty livers that actually is damaging. So that wasn't working so well. So our other ways to get it to the liver might be through delivery and technologies we'll talk about in a moment, like peritoneal delivery. That goes directly to the liver and the portals circulation. And there may be some other ways as well, including oral insulin. And then the smart insulin stuff, it's amazing. Like they have these linker molecules or even changing the insulin itself so that it just changes its shape when blood sugar is higher and makes it more likely to bind and act. These truly are amazing things. But the comment I want to make about that was that I don't know whether they'll be perfect, like you can just take a shot a day and it'll cover all your meals. But if you imagine for people with type 1, using such an insulin even in a pump will help. The pump is going to modulate and give more when sugars are higher and less when it's lower. But on top of that, the insulin can be doing its own adjustment. And there's these other things where you can add up each of these little benefits that I have a feeling are going to help us get somewhere for type 1 diabetes management, like much farther ahead.
Super exciting, and it's amazing that there are no limits to what biochemistry can do in developing insulins. So can I ask, there are many people with type 2 diabetes that need insulin, but for different reasons than people with type 1 who have almost or complete insulin deficiency. Can you talk about the different ways that people with type 1 and type 2 diabetes need insulin? Because as we discussed, underlying those diseases is quite different, but both are characterized by high blood sugar. Alice, I'll put that one to you.
So you're correct to say that those living with type 1 need to have insulin on board. And that's a very important message, obviously, for the healthcare providers to be aware, but obvious, and also for people living with type 1, because we see this sometimes happening when someone gets admitted to hospital, especially when it's an older person with type 1 diabetes being admitted to hospital. There is an unfortunate assumption that because you're older, you have type 2 diabetes, and then people's insulin gets stopped, which should never happen. So I think there is an importance for the people living with diabetes to advocate for themselves in the hospital, and of course, for the healthcare providers to do a better job of recognizing that. But that's sort of type 1 diabetes, have to use insulin. In the type 2 diabetes space, there are multiple players that have resulted in the diabetes developing. But one of them is the fact that the pancreas is not able to keep up with the demands of the body because the body is somewhat resistant to the insulin. So therefore, in someone living with type 2 diabetes, absolutely, insulin is one of the tools to help control sugar. And as the journey progresses with the type 2 diabetes, many will require insulin to sort of supplement what the pancreas is not able to make enough of. It's still making it, it's just not making enough. And there's no amount of oral medications or other medications I can give if the pancreas is tired. And that's usually what I say to patients. Your pancreas is pooped. Your pancreas is tired. It's not able to make enough insulin. So let's help it out. Let's sort of supplement it with what it would naturally try to make, but is just not able to make enough of anymore. So the concept is still replacement. I think that's a terminology I like to use when talking to my patients, because it is replacement therapy. It's replacing that which your body would have made on its own, but because of a variety of reasons, the machinery is not able to do it anymore or not able to do it enough. So let's help it out and let's supplement it.
Thanks. And one question for Bruce before we move on. Can a person who has been treated with insulin ever get off insulin completely? And that's obviously a totally different question when it comes to type 1 or type 2.
Yeah, so for type 1, yes, when we have a cure. But until then, no, it's just there's such danger. Even if you have huge temptation, I haven't eaten for days, you always need a certain amount of insulin preventing the unchecked production of ketones, because high ketones means acidity in the blood, and that kills us. So the answer, you can never say never and never say always, but in this case, never go without insulin with type 1 diabetes. But for type 2 diabetes, for sure, because for sure that it is possible. And it depends on, in type 2, we know that there's a number of factors that are leading to the insulin resistance, so insulin not working well, and the not being able to make enough insulin, a whole bunch of factors. So if your factors had to do, let's say, with your diet, very, very high fat diets interfere with how insulin can work, and suddenly you're able to improve that, well, that's something that's really helping. You may, even though you were getting insulin, you may be able to come off of it. Or if your diabetes happened to be driven by a more sedentary lifestyle and a lot of weight gain, and you were able to take charge of this and able to stabilize your weight and maybe even ideally lose weight, there may be a capacity to come off of insulin. Because the idea, as Alice has said, is that the body is not using insulin normally, so it needs more insulin to keep the sugar normal. And so there's a certain point where you need more still, and you can supplement that with an injection to get more still to normalize the blood sugar, but you're still making an awful lot of insulin. And if you can just take that edge off, help the insulin work better, there's still a lot of insulin production there to make use of. So it is possible, definitely, to come off of insulin. I do not recommend seeing that as curing type 2. One always needs to be aware that this problem happened, and it was big enough a problem that sugars actually rose to abnormal levels. And so that risk will always exist in their life. It's just, can they shift the management more from drugs like insulin more towards diet, exercise, other types of medications, perhaps pills or other injections that help insulin work better, and never to see it as a failure if they're on insulin, or a success if I guess it is a success if you've come off of insulin, but all of these are ways to manage type 2 diabetes.
Okay, thank you, Bruce. We're going to turn now to technology. So I'm going to stay with Bruce for this question and ask you to tell us about some of the most exciting advances in this area.
Yeah, I think it really is exciting using technology, and we've been focused on putting insulin under the skin through the technology. Here's an insulin pump that has a catheter, either with a long tube or a catheter directly from the pump that sticks on to us, a patch pump. It's basically the same. It's just sort of the user's preference. Do I want it stuck to my body or with a tube? And that puts insulin under the skin. So that depends on rapidly absorbing insulin, just as Alice was talking a moment ago. But it has to go into the general circulation. So what would be way better is to have a catheter that goes into our peritoneum, so our abdominal cavity, because all the blood vessels in the abdominal cavity, they go directly to the liver. So the insulin would act directly where it needs to. And these have actually been tested for a couple decades. They were in pig models, and then there's actually about 500 people around the world who are using intraperitoneal ports. The problem there is that if you get infection into the peritoneum, it's not quite as bad, but almost as bad as getting it in the blood. It's very dangerous, so it's risky. But I feel that that's a solvable problem. It's just right now the subcutaneous insulin with pumps has had so much traction and so much development. So now the question is, rather than doing open loop therapy where you're managing your pump with blood sugars through your own decision making and with the help of your team, why not have algorithms that make some decisions? So now we've had these in Canada for a few years, and we have more available. And they do really well. They do help with blood sugar control. There's no question, especially when we're not eating. They modulate. What they're doing is just adjusting the background basal insulin. So they work best when we're not eating. When we eat, the systems that we use now are called hybrid closed loop. So it means a hybrid of automatic basal plus the person, the user, deciding or telling telling the system when they're eating and making the best dose estimation of that insulin, usually through carb counting. So that's the hybrid closed loop. So it still depends a lot on the user for food. You can do terribly on a hybrid closed loop system as long as you're not really paying attention to letting it know before you eat that you're eating, and being pretty good with the amount of telling it the amount of carbs that you're eating. On the other hand, you can do really quite well. So there's been a number of algorithm adjustments, but to be honest, I think that moving forward with this technology, we're going to need to combine a bunch of other strategies. So for example, one thing I'll tell you, it's difficult is, making decisions for exercise. So people on open loop therapy, we teach them strategies for adjusting basal prior to exercise and having extra carbohydrates for exercise called X-carbs. But on a hybrid closed loop, it's making a lot of the decisions. So now you got to also make some decisions with it, and it can be a little bit complicated. It's not so bad. But one strategy would be to have, for example, movement sensors inside of a pump that could determine when you are more active, and now change the algorithm a bit to say, you know what, there's more activity. We think there's going to be more insulin sensitivity over the next few hours. Let's adjust the algorithm. Or I mentioned the technology for measuring glucose. Well, there are technologies for measuring ketones, but also measuring lactate. And lactate is a substance we make when we're more physically active. So it could detect those and alter the algorithm. So that's a place where we're going in the future. On top of this is, the whole concept with the automated insulin delivery is that it's looking at the sugar and adjusting the basal insulin in the background to adjust to it. The same way the smart insulin that Alice mentioned was. So what if you also have a smart insulin? You've got two things adjusting. Or on top of that, big area of my research has been adjunctive medications. So medications we typically use in type 2 diabetes to help on top of insulin in type 1. We see that when someone, for example, a drug like a sodium glucose link transporter inhibitor, these are the drugs that help you pee out more sugar, especially when your sugar is higher. So if you go into a night with a higher sugar, it's helping to bring your sugar on its own down during the night. So imagine that on top of adjusted insulin with a algorithm, on top of a smart insulin that's adjusting its activity. We could probably get a lot closer. And then the other adjunct medication is using glucagon, the anti-insulin hormone, where you could use an automated insulin system that's more aggressive with the insulin dosing, knowing that it could have a second chamber that has glucagon in it that goes under the skin in microdoses and can help, if someone's dropping too fast or going to hypo, help bring them back to the normal range more quickly. And so those are under active development as well. Dual chamber insulin pumps that have glucagon and insulin. Here, the real accomplishment in the last couple of years has been the development of a glucagon that's as stable as insulin in a fluid, so that it can be used for many days. On top of this, we've got a lot of these things I've mentioned could even help people who are on injection therapy. So for example, having an app that's linked to a continuous glucose meter that can also help with dosing decisions and alerting and activity monitoring, and a smart insulin. So it may not depend on pump therapy. And then I would just say maybe the key point to all of this is that we've got these multiple means that we can add on top of each other into an automated insulin delivery system that might get us closer to a fully automated system.
That's a lot to take in. There's a lot going on. My question is, what does the ideal look like? Is it something we don't have to change our consumables? Is it a single device that has all the components built in? Your phone does all the bolusing for you. What does the ideal look like in a few years' time?
Yeah. Well, I would say the ideal looks like a bunch of cells that make insulin and respond to insulin that we stick in our body. And I guess we'll be talking about that shortly. And what we're talking about here is sort of something to get us by until we have that's acceptable. So for example, listen, we're going to be seeing in the next I don't know, I always am wrong about these estimates, but pretty soon, insulin catheters for pumps that last more than 3 days, they'll last a week, and, sensors that might be longer lasting and smaller. I think, to me, the end game would be to have something that maybe has some burden. I have to change it and put it on my body, but less often with less inconvenience, but something that's more fully reactive that I can put on and not think as much about my diabetes, or only think about it in the really extreme situations. I have a really sick day, or I'm running a marathon and doing like exercise way out of the ordinary. Those times maybe I need to do some adjustments. But I think with all those layers of little solutions that we're going to see gradually over the next few years, I'm hoping that for my typical day, I can have a system that I can just put on, let it worry about my diabetes, and do reasonably well with my blood sugar control.
Turning to Alice now. Alice, can you talk a little bit about DIY or do-it-yourself closed-loop systems, please?
Absolutely. And this is something that has been around for several years now. And I certainly have a number of patients in my practice who do take advantage of the DIY systems that are out there. And I'll sort of share with you my philosophy or my opinion around it. I think it is very important for people who are using it to recognize that the systems have not gone through the usual regulatory approvals that the commercially available systems have. And I think that's an important conversation to have. But at the same time, I'm a firm believer that the person living with diabetes is the captain of the ship, right? Is the person who really ought to make decisions about their bodies and their health and how they wish to manage their diabetes. And my job is very much as a guide, even if that's even the right word, is the person sort of go along with it and to help ensure safety. I think that's an important piece of the puzzle. So I personally have had no ethical issues with the idea of the do-it-yourself pump therapy. I think it is important that we have honest conversations about it. I would hate for my patient to feel like they couldn't tell me because they were afraid that it would somehow be negatively perceived. And there is that perception out there with some of my colleagues, to be frank. So that I would not want to see that happen. I think understanding the pros, the cons, the limitations, and the concepts of safety, I think, are critical. And I think as a system, we need to reflect on why were they created in the first place, right? I mean, they were created in the first place because there was a need, because there was this sense of things were not moving fast enough. And there's this great talent and expertise that exists out there, right? People living with diabetes or parents of people living with diabetes who are engineers, who are really smart people who can do this kind of stuff. So they sort of felt like, well, if it's not being created fast enough, I'm going to do it. And I applaud that philosophy. But again, the issues of safety, I think, very much need to be discussed and open conversations with the entire team. And therefore, I need to learn about it. I need to learn about it as a healthcare provider so that I can be an ally and help as opposed to being a barrier. That's very much my philosophy on that process. It's also a message to the commercially available companies to say, hey, guys, it's time to wake up, smell the coffee, and continue with all the great work that you're doing so that you can catch up, if you will. I mean, catch up is not the right word, but that you can also create the technologies that people are asking for.
So we've heard a lot about recent improvements, but it remains true that complications are still a concern in many people living with diabetes. So staying with you, Alice, can you tell us about a few advances in prevention and management of diabetes complications?
The good news is there have been lots in the type 2 diabetes space. In the type 2 diabetes space in the last, I guess it would be 6 years now, we've had good data looking at certain classes of medication, specifically the SGLT2 inhibitors and the GLP-1 receptor agonist. It feels like alphabet soup. It is like alphabet soup. So those are the letters, but those two particular classes of medications have been shown in multiple large trials to reduce cardiovascular, cardiac, heart-related, as well as kidney-related complications in people living with type 2 diabetes. Not everybody, but we have a good sense of who are the people that are going to benefit. So that has been a huge advance in the type 2 diabetes space. But we've also known for decades already about the importance of multifactorial approach, particularly in any diabetes, but really proven in type 2 diabetes, of the A, B, C, D, E, S's is how we've talked about it. So A1C, reaching target, blood pressure, cholesterol, drugs to protect the heart, exercise, eating, smoking cessation, so not smoking, and then, of course, screening for complications. So making sure that people are seeing an eye care professional at least 1 to 2 year intervals, getting their urine tested for protein in the urine, having their feet examined, and taking good care of their feet. So that's very much about a team approach in order to address all of the potential things that could lead to complications. So that we've known about for decades, and we just need to keep doing that. But from an advanced perspective, we do have these additional classes now that have shown extra benefit above and beyond glucose lowering. They seem to have benefit specifically for the heart, the brain, and for the kidneys.
But now, we are in an unprecedented time of advance with cures research. So I'm wondering if you can give us, in a nutshell, an overview of the different areas that are being explored to cure diabetes and a quick summary of those.
Yeah, maybe it's better for someone like me who doesn't have particular expertise in the cell-based therapy area to just sort of give an overview. But the bottom line is that people with type 1 diabetes, generally their immune system's attacking their own cells, and so they disappear. Maybe not 100%, but mostly enough so that they can't generally control sugar or survive without insulin. So a simple thing would be to take those cells and replace them. If someone's kidney fails for whatever reason, we often take it from another human and stick it in to this human, transplant therapy. So here we know that pancreatic transplant, so this would be where someone unfortunately needs to die and donate a pancreas after death, that can be transplanted. It's actually really successful for managing diabetes. I wouldn't say cure, because remember, whenever you take an organ from someone else, you need immunosuppressant drugs, so that comes with their own problems. And also transplanting a pancreas, we shouldn't forget that the pancreas, one of its little jobs is making insulin and the hormones related to it, glucagon and the others, somatostatin. But it also makes digestive enzymes that it puts into the gut to help digest food. So when you transplant this, if those leak, they digest the body. If they get into that abdominal cavity or around it's a very tricky surgery. So people who survive the surgery do well, but there is still a bit of a risk of death and illness at the time of surgery. So there you go, that's one thing. But of course, here in Canada, we're extremely proud of this notion of taking the pancreas and digesting it and skimming off the insulin-producing cells. And this was really refined in Edmonton and called the Edmonton Protocol, where they took these cells and now inject them into a vein that goes into the liver, and so they get stuck in the liver. Now, of course, if you took anyone else's cells and put them into anyone else, you need immunosuppressant drugs. But remember, in type 1 diabetes, the problem is that, in particular, people like me want to kill insulin-producing cells. So if you put someone else's insulin-producing cells, I'll mount a reaction to them. So they do need, there's a few problems. One is that they need immunosuppressant medications. But the second is that one transplant never does or rarely does the trick. They tend to need 2 or 3, possibly even more transplants. So now you have an issue with people, in order to donate their pancreas, unfortunately do have to die. It's not like a kidney where we have 2 of them. So it would mean that the supply of these is very limited. So the other way to really ramp up production of cells would be to look to finding human cells that we could now, that are immature and that could be grown and multiply to make lots of these insulin-producing cells. So these, of course, are stem cells, and we've got a few sources for them. Let's go to the embryonic stem cells. There's been a big push with these cells to make them into insulin-producing cells. One of the big tricks has been getting them to become fully mature insulin-producing cells. There was a group that actually a number of these research areas have commercialized. So one of them was out of California, where they actually took these not so mature cells, but looked like they might be able to produce insulin. And they stuck them inside a capsule and stuck them inside of mice and rats, and blood vessels, they put them under the skin. Blood vessels grew around, and it looked like they produced amazing insulin-producing cells, but also glucagon and somatostatin, the other hormones that help control insulin. So that was brought to humans a handful of years ago, but there was a number of technical issues. I was praying that this would be the thing that would move us forward very quickly. It didn't, and now it looks like they need to have the capsule, the ability for blood vessels to grow into them and interact more with the cells, which means they're no longer protected by the immune system. So we need we would need immunosuppressant medications. In Canada, we have amazing groups in Vancouver and in Toronto that are making a lot of headway to get to those cells, but we're still left with that problem, even if we can replace those cells, that our bodies want to kill them. And so there's a number of technologies, and a group in Harvard's doing this, and in Canada, to look at designing those cells so they're less visible to the immune system. So take advantage of the fact that we're making new insulin cells from stem cells, but also being able to change their characteristics so they can fly under the radar a little bit of the immune system. So do we have these working perfectly in animal models now? No. So does that mean they could go into humans right now? No. But it is amazing the pace of this research in the last decade.
Well, and I think there was a new trial enrolling in the States with a fully differentiated product, which is super exciting.
Yeah, that is.
And so, there's quick progress for sure. So we've talked a lot about cell replacement therapies now. Can you just give a few comments on immune therapies? We talked about one immune therapy previously when we touched on prevention. Can you give a few minutes on immune therapies for cure?
Yeah, so I guess the idea is that, especially in early stages, so, immune researchers like yourself, Sarah, talk about diabetes differently than clinicians. So diabetes onset is really, the disease is said to be starting as soon as someone has antibodies. And then they can have antibodies with some abnormal blood sugars that don't meet a criteria for diabetes, and then they can have clinical onset. And so we talked about that kind of phase 2 or the stage 2 where people have some abnormal blood sugars and antibodies. They're about to develop diabetes, it looks like. And we have that teplizumab immune therapy that helps. It actually, in new onset diabetes, had an effect on increasing insulin production. It's measured by a thing called C-peptide. And actually, there's a bunch of medications at that stage, new onset diabetes, that look like they have some effect. I could rattle off a bunch of their names, but essentially they're in the immune response, which involves, cells that look at the antigens and are tricked into thinking that they look like foreign antigens, to inducing things called T cells, and also the help they get from things called B cells. There's all these interactions between them that can be blocked, often by monoclonal antibodies or other strategies. So a number of these have had some effect. And in my own opinion, and maybe, Sarah, you're hoping to hear more about this from me, but in my opinion, we're likely going to need to be showing some proof of concept of individual medications or drugs like these that have an effect on increasing C-peptide to some degree, even though they're not curing diabetes on their own, but now looking to combine these on multiple stages along the pathway of that abnormal immune response. So we're focusing on new onset diabetes, like in the couple of months after someone gets diabetes or earlier, predicting who's going to get it. But my hope also is, because we've learned that even people with many years of diabetes, some retain some insulin production, some insulin producing cells. My hope is one day we'll have good enough or strong enough medications that might even help to resurrect those little populations, so that even someone like me who's had it for years might be able to benefit from immunosuppressants to bring these cells back to life.
Thanks, Bruce. And before we close, Alice, do you have a favorite area of cure research you'd like to comment on?
So I think Bruce has done a beautiful job talking about the type 1 diabetes cure piece. I think the only thing I'm going to add is maybe on the type 2 side of things, when thinking about cure. I'm not sure cure is the right word. Remission is often the word that's used instead. And there are some excellent data already available of therapies already available that are effective. So for example, bariatric surgery in appropriate people have been shown to create remission in type 2 diabetes so that their diabetes goes away, if you will. And it can be very effective and quite powerful in the right person. The other approach that has been effective is from a dietary perspective. So there was a large study that was conducted out of the UK in multiple centers with a very specific kind of dietary intervention, which was low calorie, but also lots of support around the patient. And again, was very effective in creating remission of type 2 diabetes. So those things are here and available and doable now. And we certainly do discuss with people living with type 2. So that would be the only piece that I think I would add to this conversation, just looking at it from a different perspective.
Thank you both so much for your insights. I'm certainly inspired speaking with you and hearing about research every day that we know is going on around the world. So I think we have a lot to look forward to, and thank you everyone for joining. We welcome some questions from the audience now. Hello, everyone, and thank you again for joining. We have a lot of questions appearing in the question feed, and just as a reminder, please aim to enter your questions in that channel and not the chat, because we are not monitoring the chat for questions. So we only have a few minutes, and I'd like to start with a question for our international audience. Amy from the Philippines is commenting that insulin is too expensive in the Philippines. So sometimes patients with type 1 diabetes often take an oral medication rather than insulin. And can that provide any benefit? And Alice, I'm going to turn that one to you and ask if you can also comment on access to insulin and what's being done about that, because we know it is an enormous challenge around the world.
Absolutely. And I think many may be aware about the WHO, World Health Organization Diabetes Compact that was announced today, I believe, which is looking at a global initiative to try to improve diagnosis, prevention, if that's the right word, and also access to therapies in terms of those living with diabetes. And insulin would certainly be on that list. So despite celebrating 100 years of the discovery, you're absolutely correct to say that access around the world is not equal in any way. And it's good to know that WHO is focusing on this, which will then raise awareness. And it's going to require many stakeholders to be involved in order to make that happen. From your specific question about someone living with type 1 diabetes being treated with oral, I guess it would partly depend on what stage of the game they are at from a pancreatic function perspective. So earlier on, perhaps therapies that could make the pancreas put out a little more insulin might be temporizing, but that's really all it's going to be, is a temporary therapy. And that individual living with type 1 is ultimately going to require insulin in order to live. So finding ways to access it is going to be critical. So those living with type 1 need insulin, and oral medications are really not effective and are just temporizing measures in the early stages.
Okay, thanks, Alice. Over to Bruce. We've had quite a few questions in the Q&A about new technology for monitoring blood glucose, such as implantable sensors or even smartwatches that would be non-invasive. Bruce, can you give a few comments on what's ahead in that area?
Well, so much of the success, there's a number of different technologies that can be used to measure or estimate blood sugar. But the main success has been when you take a little electrode and coat it with an enzyme called glucose oxidase and put it under the skin and let it get bathed in the interstitial fluid, which is the kind of the fluid under our skin. And it's in has pretty close concentration with what's in the blood. Maybe there's a bit of a lag, but that has had the most traction. So it's not taking blood, it's interstitial fluid. And so most of the major investments, this looks like it's the most practical, the most reliable, the most accurate way to go about it. But there are other interesting technologies. People in the chat have mentioned tattoos, which kind of is a similar idea, interaction of fluid in the skin, that same technology. But there's other things using infrared or other, you can send light signals, and you can send sound signals, and you can send vibration signals, MRR, magnetic resonance. These are all technologies that you can use to estimate how much of any substance is just beyond the sensor, like in a finger or on a wrist. And so these could be used for glucose as well. So there's a lot of interesting stuff. I'm kind of excited about a few of these areas, including the magnetic resonance, the idea there might even be a glucose ring, which can communicate with another device, and it can estimate the glucose and also other substances. Alice was talking about being a Trekkie, could look at sodium, could look at ketones, lactates with this. I'm excited about that, but these are, all the layers of testing they need to go through. It's quite a bit behind what we're using now as the interstitial sensors that are available in a lot of countries.
Okay, thanks, Bruce. Alice, we have a question about diabetes that isn't classically type 1 or classically type 2. Is it possible to have a type of diabetes that has versions of features of both?
Absolutely. And we spend a lot of time talking about type 2 diabetes, type 1 diabetes, type 2 being most common. We also talk about gestational diabetes, but there are other forms of diabetes. There is what's been sort of layperson referred to as type 1.5 diabetes, that latent autoimmune diabetes of an adult, where one is presenting as an adult with features a little bit of both. And then those patients may often evolve into requiring insulin like someone living with type 1 diabetes. There are also monogenic forms of diabetes, which are genetic forms of diabetes that are not specifically type 1 or type 2. And those are important to identify because the treatments, depending on the type of monogenic diabetes, may in fact be different. So those types of diabetes are much less common than type 1 and type 2. But yes, there are definitely people who don't quite fall into those categories. And therefore, it's important for you and your healthcare team to do the necessary tests to try to identify what type it might be. At the end of the day, though, I think the core question is, are you somebody who needs to be on insulin full time? Because again, from a safety perspective, I think that's the most important question to answer, because then you'll know, even when you're not eating, even when you're not drinking, even if you're in hospital, whether or not insulin must continue to be given to you.
Okay, thank you, Alice. We only have a few minutes left, but I'm going to try and whiz through a few last questions. So here's a question from David addressed to Bruce. For youth onset diabetes, what is the relative risk of complications in type 1 versus type 2?
Well, the reality is we don't know exactly, because the kind of the big increase in the type 2 diabetes cases in youth is sort of a newer phenomenon. We've been seeing it or recognize it only in the last few decades, and a lot actually in Indigenous populations in Canada and around the world. So, but what I can say is that if you have diabetes at a younger age, you have more time to get exposed to higher level of sugar and develop complications. So that would be kind of more dangerous for type 1 or type 2, and maybe even more dangerous for type 2, because as you know, type 2 can have like sort of a slower onset. So people may not realize that their sugars are running high. They don't feel as sick as when they have new onset of type 1 diabetes. So that's a dangerous thing. Secondly, in type 2, the way it's happening, it's being accompanied by other things that aren't so healthy, like higher blood pressure, higher cholesterol, higher uric acid, a bunch of things that themselves can push on top of damage that blood sugar does to cause complications. So we fear that type 2, there might be even a greater risk of complications in the long term, because it's not just as simple as blood sugars being off or not.
Okay, and Bruce, I'm going to stay with you for this question. Can you talk briefly about combining insulin with options like metformin for type 1 and the benefit that that provides?
Yeah, so metformin's been tested really nicely in a clinical trial. Actually, not so much to see if it helps with blood sugar or weight, although we could see it was they were wondering whether it might decrease risk for large blood vessel disease, like long-term risk of heart attacks and strokes. And it didn't really look like it does protect from that. And on top of that, the benefit in terms of blood sugar was very small. It was around a 0.1 or 0.15% A1C benefit. And there wasn't really a tangible benefit in weight either. So on average, in type 1 diabetes, metformin is not a solution. It's not helpful. But it's used for other reasons. For example, there's a thing called polycystic ovarian syndrome that can occur in anyone, and so it can fall. And sometimes we use it just as an extra way to try and help and see, but I wouldn't keep someone on it for a long term. It won't, on average, in type 1 diabetes, metformin will not help. There are other medications that we've looked into that I do as these adjunct drugs adding on to help insulin work better that are available in parts of the world, but not here in North America. Oh, I shouldn't say that. One of them is in the US and not in Canada. But I honestly think this is going to be a big deal in type 1 diabetes, using these medications that have been so helpful to help blood disease by adding them on to insulin.
Okay, thanks, Bruce. And one final question for Alice. What is the one thing you're excited most about in the future of insulin development?
I think my greatest excitement is around the concept of the smart insulin, which we've already talked about, so I won't repeat myself. But I do want to share one final anecdote, and Bruce may not remember this, but I probably heard him say this probably 20 years ago. And yes, Bruce, this does age us, but we have known each other a long time. And he had said that one of his dreams was that someone would be diagnosed with type 1 diabetes, let's say a child or an adolescent, and then they would have a day procedure at a hospital where they would have an implanted glucose sensing device that would be connected to a peritoneal, so in the abdomen, insulin delivery device. And then they would leave that day procedure and not have to think about their diabetes, and maybe go in every 6 months for a change in the battery or something like that. And I remember him saying that at the time, and me thinking, wow, that's a great idea. And I hope that's something that we will in fact see. So the technologies are improving so quickly, and every little bit of that dream, I think, is being worked upon. So that has really stuck with me as something that Bruce had said many years ago.
Well, thank you both very much for your inspiring overview of these research progress. And thank you everyone for your fantastic questions. I'm sorry that we didn't have more time to get through them. So now I'll turn it back to Dr. Jackie James to close this session.
Yes, we certainly could go much longer with this topic. Thank you so much, Bruce and Alice and Sarah, for an amazing session. We do need a break, though. Our brains are probably about to explode right now. There's so much great information that's being shared. So we are going to take a break right now and resume in 10 minutes. So I will remind you that we're coming back, but you do have to switch over to the next session, which is called Celebrating the Lives of Those with Diabetes in the Modern Age. And that's on your panel as a room that we have to move from this session into the next. When you go there, you'll find some great videos continuing our stories about those living with diabetes. But I do realize that we may have to run to the washroom, have something to eat, have a snack. Originally, when we planned this, we were going to have a little snack for everybody. And of course, now we have to just have our own snacks. So we will see you back in 10 minutes to continue the program. Remember, you have to switch the room and go into Celebrating the Lives of Those with Diabetes in the Modern Age. See you soon.